they go wrong. And so I grabbed it, and of course, she's 36 months. And it's just one of those. We've all been there, having the pregnant patient with chest pain, anything from completely benign to OMG, this is painful. So this patient is in front of me, pulse is 112, blood pressure is 100/65, and her SAT is 92%. So of all these vital signs, I ask you, which is the most concerning to you right now? Saturation, I hear heart rate. Who says the heart rate? Who says the SAT? Who says the blood pressure? All right. So they're all concerning. They should all give you pause and think about what's going on with this patient. But hopefully by the end of the lecture, you'll see why saturation for this particular person is the most concerning. All these can be normal variations during pregnancy. So what I want to do is talk to you about an approach to the patient who is coming to you, who's pregnant, who's either critically ill or you have a high suspicion that they may be critically ill. They're in front of you and say, there's this possibility. What are the things you're going to do? We're not going to go over specific diagnoses per se because you all know how to handle that. I want to give you an algorithm to take that person in the first 5 to 10 minutes and really make a difference with some very simple and free things that you can do for that patient. So just as a review, remember that trauma is still the #1 cause for maternal mortality. That's still the case. That hasn't changed, unfortunately. The reason why medical issues have not been more important is because patients tend to be younger, and even if they don't have access to health care at baseline, when they get pregnant, now they have access to health care during their prenatal visits, and they can get plugged into other types of health care. But when patients are pregnant and they develop critical illness, the mortality is extremely high. So not much incidence of critical illness in pregnancy, but when it's there, the mortality is extremely, extremely high, and we'll go over that. And of course, the #1 determinant of fetal mortality is maternal mortality. But as you're caring for a patient, a mother who's critically ill, things like giving them transfusions of blood product, maternal shocks, are all risk factors for the fetus developing mortality. Now, I mentioned that patients are young, they have access to health care, so that's why critical illness is low, but over the years, critical illness in pregnancy has gone up. And that's because we're getting better at taking care of chronic illnesses, and we're able to have women who are having babies at older ages with the improved technologies. That's a good thing, but it also coexists that there's more critical illness, that these patients, as they're older and have more comorbid disease, have less reserve during the stress of pregnancy. So the fetus, from time 0 all the way to delivery, changes every physiologic system in the mother's body. And it's truly, truly amazing. Every system, the skin, the musculoskeletal system. But the thing we have to focus on, the thing that's going to kill the patient, are the 2 systems you see here. Cardiovascular system and the respiratory system. I like to call it perfusion and diffusion. First things you need to care about when that patient who's critically ill and pregnant comes in, or they're potentially critically ill and pregnant and you haven't determined yet. So by the end of the 3rd trimester, the maternal cardiac output goes up by 50%. And this is a combination of things. This is a combination of the myocardium getting stronger, the chambers dilating so there's more efficient stroke volume, the total plasma volume increases, and of course you all know about the physiologic anemia of pregnancy where there's increased red cell mass, just not as much as the plasma volume. So that sounds like a really good thing. Here's the problem, is that 25% of that increased cardiac output is all going to the placenta to take care of the fetus and exchange waste and nutrients. So while it sounds like a good thing, 25% of that goes right to the placenta, and there's little reserve should there be any cardiopulmonary instability. So that's something we have to keep in mind. The pulmonary system also changes. And again, these are all normal changes we're talking about for right now. Now, the mother's breathing for 2 people during pregnancy, and there's no way to increase the oxygen tension within the blood, so that's why red blood cells are increased, to increase the overall oxygen capacity of the blood. And the minute ventilation increases to accommodate that, so mothers have a physiological tachypnea of pregnancy, and as a result, there's a respiratory alkalosis that occurs during pregnancy. So PaCO2s of 30 or 32 are not uncommon if you do a blood gas. Other physiologic changes occur because as this baby is developing, it's pushing up on the diaphragms. And what it does is it decreases total lung volumes. It also decreases what's known as the FRC, the functional residual capacity. And that FRC is sort of like your reserve tank. You know, when you're driving and the light comes on and says you better get to a gas station soon, you have a reserve tank. Well, FRC is just that, and when the fetus pushes up on the lower part of the lungs, you lose that reserve. And subsequently what happens is, normally when you have a patient who's starting to drop their SATs, 98, 97, 96, hang out for a while, 95, 94, for pregnant patients, they drop off the curve very, very fast. So if you have a patient that comes in and they're already having low SATs, it's not going to take much for them to go over the edge because they have a loss of that functional residual capacity. Another change that happens during pregnancy is as the breasts become enlarged, as there's more fat deposition, these external forces push down on the lungs and create a restrictive type of lung disease. So the breaths there's less reserve to take bigger breaths should the mother get into stress. So everything I've described has all been normal. And it's amazing that more patients, more mothers don't die during pregnancy because these are people who are hanging on to the edge of physiology. It's a very fine line to cross over into pathologic state. So let's talk about some of the goals that we have when patients come in and they're sick. Now, what I'm about to show you has no randomized clinical control trials. They have not taken pregnant patients and said, we're going to give you a map of this or a systolic blood pressure, and the rest of you, well, I'm sorry, you're in the control group. We don't have that. We're extrapolating from animal studies, from OR data, from critical illness. So what we have are case series and cohort studies. But the best evidence I could give you is that a map of 65 is generally okay for the pregnant patient, just like our regular patients. If you don't want to go by map, a systolic blood pressure of greater than 100 is also adequate. Now we know that there are some patients during pregnancy that have an essential hypertension of pregnancy. So what do you do for those people? If you have access to their clinic notes or that patient knows what their baseline blood pressure is, aiming for 80% of what their normal blood pressure, normal for them is, should be adequate. It's the best evidence that we have. How about for the pulmonary system? Again, these are extrapolated from animal studies and OR stuff. This is all we have. And the best that we know is that aiming for a saturation of greater than 95% or PaO2 greater than 70 is adequate for the mother and for the fetus. Now, I don't advocate doing blood gases routinely on patients, but what I do is I look at the saturation. If we're greater than 95, then we're good for now. If we're less than that, I have concern, and then of course, remember, they fall off that curve relatively quick. Now, if their SATs are less than 90%, that means their PaO2 is less than 60. This is dangerous. This is dangerous not only for mom, because she's going to slip off that curve, but it's especially dangerous for the fetus, because that fetus is relying so much on maternal oxygenation. For PaCO2, we talked about the normal range during pregnancy, because of that tachypnea that's occurring to get more oxygen in there, of 30 to 32 as being your baseline. Here, a normal PaCO2 should be concerning. It should be concerning for two reasons. It's telling you that the mother is tiring out, that she can't compensate, she can't keep up with normal physiology. And whenever you develop acidosis in the system, and this would be a relative acidosis, even though the PaCO2 is 40, you get uterine vasoconstriction, and now the fetus is not getting blood flow, not getting the nutrients, not clearing waste sufficiently. So what are we going to do? What's going to be our approach to patients who are critically ill and pregnant? So when they come in, if they need volume, you're going to give them crystalloids. And it doesn't matter what crystalloid you give them, just like non-pregnant patients. What labs are you going to send? You're going to send all the same exact labs that you send if they weren't pregnant, including lactate, blood cultures, VB2. It's all the same. How about transfusion of blood? Well, besides their blood type, everything else is exactly the same as a non-pregnant patient. How about scanning patients? You can scan a patient, a trauma-pregnant patient, from head to toe and still be within the safe radiation range. Now, I'm not advocating scanning, pan-scanning. Every pregnant patient that comes in, you still got to believe in selective scanning. But I would never withhold a diagnostic study on a pregnant patient because a missed injury is going to kill that person. You sacrifice that perfusion and defusion if you miss an injury. So do selective scanning and don't withhold any radiologic studies, but know that you can scan a patient if you think that they need all those images, and you'll still be well within the range. It's cumulative, so the next time they come in, obviously it adds up. But one time, it's well within the regulations and the recommendations from guidelines. So here's the mnemonic I want you to remember for your next shift for patients who are critically ill and pregnant or potentially critically ill and pregnant. Because this is what you're going to do when you meet the person at the door. And here's the mnemonic TOLT. You're going to tilt them, you're going to give them lots of oxygen, you're going to put in some good access, some good lines above the diaphragm, and then finally you're going to figure out when their due dates are, and then you're going to call labor and delivery. Let's go through these one by one. So tilting the patient. After 20 weeks of pregnancy, that uterus is big enough that it's going to compress the aorta and the IVC. And that compression can sacrifice up to 30% of the patient's cardiac output. Obviously, it gets worse over time, but 20 weeks and on, you have to worry about this supine hypotension syndrome. So the way you fix that is you roll patients on their side, left lateral decubitus. This is going to take that gravid uterus off the IVC and the aorta. So you can do it with the backboard, that's one way of doing it, but I think the best way of doing it, if there's no spinal precautions, is just to roll them straight on their side, perpendicular to the bed. And when I meet a patient, they tell me that they're pregnant, they're far along, and they have any symptoms, and they could be critically ill, I just roll them on their side before I continue talking to them, because I want to get that uterus right off that aorta and out that IVC. That's it. It's free, it's simple, it's easy to do. The next is oxygen. Now, there are lots of studies that show the harms of giving patients too much oxygen, especially critically ill patients. So I'm not advocating that this patient should be on 100% FiO2 for the rest of their hospital stay. But when you first meet that person and you're unsure if they're critically ill or if you know they're critically ill, give them good oxygenation because, again, they're going to slide off that oxygenation curve very rapidly. So quickly putting non-rebreather on them is a clever move. And of course, once you find out that they have a problem, you can switch over to high-flow humidified nasal cannula. How many of you folks have that in your hospital? Yeah, every year more and more hands go up because I think this is becoming part of our emergency armamentarium. It used to be something that was only used upstairs. And for those of you that don't have it, essentially what you can do here is you can titrate FiO2 for your patients. You can titrate the temperature that you're giving of the oxygen that's humidified. But most importantly, you can titrate the liters per minute. And this essentially works as CPAP. Now, it's not a lot of CPAP. It's almost like diet CPAP, if you will, or CPAP light. It gets you about 8 centimeters of water. But it might be just enough to splint open that person's airways. And this is how it looks for those of you that haven't seen it. None of my residents modeled for me, so I have to do all my own stunts. So no residents were harmed in the making of this presentation. How about non-invasive? CPAP or BiPAP? Well, most people would actually advocate against that for these patients. And why is that? The reason why is because pregnant patients, especially later on in pregnancy, are high aspiration risks. And it's for a variety of reasons. The first thing is because of all the hormones that are going around the body, the lower esophageal sphincter is more relaxed, and there's a higher aspiration risk. As the fetus is pushing up into the stomach, you're pushing gastric contents up. And also, again, because of the hormones, we're decreasing intestinal transit. So for all these factors, there's a higher risk of aspiration at baseline. Now put a positive pressure mask on there where some of that positive pressure is getting down to the esophagus, insufflating the stomach, and now you're taking a person who's already kind of hanging on their oxygenation curve, and now you have them aspirate. Now you got big problems. So I would avoid it. I'd use high flow, and if they're really sick, then you might go on to intubation. So we tilted the patient left lateral decubitus. We gave them lots of oxygen early on while we're evaluating, all 3 therapies. Now let's talk about lines. What lines are we going to use? So traditionally for resuscitation, when you want to get rapid lines in, we try to go for the groin. Rapid access, IOs, or femoral lines. But here's the problem. As pregnancy progresses and the uterus gets larger, that uterus is pushing on the pelvic veins, pushing on the iliac veins, and now you're decreasing venous return back to the heart. It's almost like having abdominal compartment syndrome. So instead what you should do is go old-fashioned, 18, 16 gauges in the ACs, and if you need to, go ahead and put a cordis in the IG or the subclavian. But you want to get something above the diaphragm, free and clear of that obstruction in the abdomen. The last part is to know when the due dates are and call labor and delivery. Now, dates are so important to know on the patient when you meet them for a variety of reasons. 24 weeks is a critical date. I'd say 20 to 24 weeks. Because after 20 weeks, remember, you get that supine hypotension syndrome. Cardiac output gets compromised by up to 30%. You also want to know if you're going to have to consult labor and delivery so they can bring down that fetal tocodynamic monitoring to see what's going on with that fetus. And then finally, the baby, the fetus, is a viable age. So if you're going to have to do an emergent delivery, it'd be better to get them on board soon, see if you need to give them steroids for lung maturity and work with them. Perhaps delivery would be life-saving for the mother. So how do you determine dates? Well, you can use the good old-fashioned wheel. I know in Epic they have a calculation. There's even an app for that. You can use your physical exam. Remember that at the pelvis, you're 20 weeks, and then at the belly button, you're 20 weeks, and then every centimeter above that is 1 week of gestation. So 4 finger breaths above the belly button is a rough estimate, if you feel the tip of the uterus, of 24 weeks. But there's pitfalls with that. If you have twin gestations, or if they have oligohydramnios and there's not enough fluid, you might have false positives. So even a physical exam is not very helpful. So I say go with ultrasound. Ultrasound not only because it's more accurate, but because you should be doing ultrasound anyway to figure out what's wrong with your patient and to help you along with resuscitation. And then you got to get on the phone. And if you don't have local OB, get on the nearest center and talk this through with them to see what they would advise. Again, for me, what I want them to do is send down a nurse with this monitoring so I can start looking at the fetus. I can resuscitate the mom. I can do the things that need to be done for the mother, but I need to know what's going on with the fetus and seeing what the safest move in terms of delivery or moving forward would be. So that's it, the 4 things you need to do when you see these patients. So again, it's tilting the patients, getting good high-flow oxygen on them, getting lines that are above the diaphragm, and 18, 16 gauges are just fine, and then finally knowing the dates of expected delivery and calling labor and delivery. So that's for patients who you're not sure if they're sick or not. Let's talk about the actually sick, critically ill patient who's pregnant. And Airway is going to be first. Because if they crash, they go down, they're going to go down hard. Remember, these patients have less reserve, they have less of that FRC. You should anticipate every pregnant airway as a difficult airway. I had a mentor who told me once, think of these as the burn airway. Because once you get in there, it could be horrible. It might be great, but it might be horrible when you get in there. So you want to be prepared as you're approaching the airway. You're already hopefully having that non-rebreather on. Put the nasal cannula underneath, crank it up to 15 liters. This is going to help them preoxygenate, wash out any nitrogen, but it's also going to help you with apneic oxygenation that you'll hopefully keep on with nasal cannula during your attempts at intubation. Positioning is vitally important. So it used to be that we said for obese patients, you want to have the ear to the sternal notch. And then we said for pregnant patients, you want to have the ear to the sternal notch. It turns out, it's outside the scope of this lecture, it turns out that for most patients, if you do ear to sternal notch, head of the bed elevated, you have increased first pass success. We can talk about that offline if you like. But get your patients ramped up so the ear's aligned with the sternal notch. It's going to give you better first pass success. It's also going to let the diaphragm work better as you're preparing to intubate this person. Now, as I said before, I've had some good mentors, and I had one mentor who said, the pregnant airway is like a box of chocolates. You never know what you're going to get. And so here's some clips from patients who were pregnant, and then here's their airways. So this is one, and you can make out some of the anatomy here. It's not that bad, right? It's not easy, but it's not bad. How about this airway right here? Anyone want to take a shot at this one? So you have to have a tremendous amount of respect for the pregnant airway. Like I said, maybe you go in there, take a look, and it's beautiful, and you're like, that Mallemat guy was crazy. This is beautiful. But it might look like this, and you want to be ready and have everything by the bedside. Not the scalpel in the next room where we can get video laryngoscopy if we need it. No, everything should be in the room in arm's reach. And who should do the tube? Who should be doing the tube? Now, I see a lot of young faces in here, so I get it. You have no idea who this guy is. That's right. I've updated the slide a little bit for you. Okay. So who should be doing the tube? I say the person passing the tube should be the person with the most experience and the grayest hair. That's the person that should take the first look. This is not the intern's tube to take a look at, because due to the changes of pregnancy, you're going to get a lot of hyperemia of the mucosa. That first pass that gets missed can result in a very bloody and edematous airway, and that might be the only chance that you have to take a look. So it should be the most experienced person first. And I say start small. You can always exchange the tube over later, but get a small tube in there first to stent it open. Like I said, if you take a look, it's nice and big, go ahead and pass your 7.5, your 8. But have a small tube in your hand for that first pass. And then always have your plan B, C, D, as we would with any airway. After their tube, what are your vent settings? Nothing out of the ordinary here. You're going for ideal body weight. Remember, ideal body weight is only based on two things. It's based on your height, and it's based on your gender. And here we're talking about female, so it's really based on your height. So look it up in MD Calc, whatever your pocket calculator. Don't memorize these formulas. But that's the tidal volume you should be using. 6 to 8 cc's per kg of ideal body weight. PEEP, this is a little controversial. So most people would say start at a PEEP that's a little bit higher. So not starting at the PEEP of 5, maybe a PEEP of 7, maybe a PEEP of 10. Because remember, that fetus is pushing up, collapsing the airways, causing there to be de-recruitment of the lung. A little bit of PEEP is going to push back and hold open some of those lower portions of the lung. So I typically start at 7. And then finally, keeping an eye on the peak and the plateau pressures for these patients, as you would for any ventilated patient. Don't forget, for the pregnant patient, really for any patient that you have, post-intubation, you want to get the head of the bed up 30 to 45 degrees. This is going to help decrease aspiration, microaspiration, decrease pneumonias for this person. This is going to help the lung and the diaphragm perform better during ventilation as well. And of course, if there's final precautions, you can always do reverse Trendelenburg. All right, the final part of this talk is talking about patients who are in cardiac arrest, the pregnant patient who's in cardiac arrest. And these two scenarios are not equal. Circulation put out a special recommendation for the pregnant patient, so there must be something special here. Let's take a look at what they recommended. They said that the rate of chest compressions should be exactly the same as non-pregnant patients, 100 to 120. Well, they said shock the patients at the same electricity as you would for non-pregnant patients. The only recommendation they said is maybe you want to take the scalp monitor out so you're not buzzing junior if the baby's crowning down there. But otherwise the same. And medications, you're going to use the same medications except amiodarone. Hold off on amiodarone for the reasons that Dr. Matu told you this morning, but also because that iodine load can hurt the fetus and they're developing thyroid. So everything is the same. What's different? This is what's different. The recommendations to use TOLT. Tilt them, oxygen, lines above the diaphragm, and know their dates of delivery. So let's talk about chest compressions. Chest compressions on a backboard with the bed tilted this way. As you can see here, it'd be really hard to get good perpendicular downward force on this patient. So it's not recommended to do it this way. Instead, what you should do is be clever. Because how many of you have about 70 to 80 people in your room during a cardiac arrest? Right? Everyone wants to come in. Even the housekeeper wants to come in and see what's going on. So I like to use everybody that I can to give them different tasks. And when I have a patient who we're doing CPR on, they'll be flat. But again, remember, supine hypotension syndrome, that's hurting the aorta and the IVC. You manually detorse or manually decompress that uterus to the side. And I have someone do that specifically. That's their job during chest compressions. And then they're part of the resuscitation. So I utilize people in the room. Pushing on the chest, there's back and forth about whether or not you should push a little bit higher on the sternum or you can push at the regular place. It was thought that maybe the uterus is pushing up and pushing the heart a little bit. The truth is no one really knows. So, I press at the same place, maybe a centimeter higher, but no major recommendations there. But the most important thing you have to remember when you have a patient who's pregnant and you're resuscitating them is 4 minutes. You have 4 minutes from the time they lost their pulse before you do a perimortem C-section. Anyone in this room has ever had to do perimortem C-section? Yeah. It's a horrible experience. I've never done one myself. I've been in the room with one happening, and it's something that we have to be prepared to do, but you hope you never have to do. If you deliver the baby, if you deliver the placenta, you can get up to 80% of the cardiac output that was going to that placenta back into the central circulation. And sometimes you can get return spontaneous circulation just by doing that. You're bolusing all the blood flow back to the central circulation. When you're doing this, it's very important to remember this is about maternal resuscitation. We all know the heroics and the stories that have been in the press about saving the baby and mom dies, and that's fine. But when you're doing this, you're trying to save mom. If you save mom, she can always have another child. And it's important to know that you want to do this for patients who are 20 weeks and after. There's no sense in doing this in someone who's 16 weeks pregnant. There's not enough of a decompression. There's not enough compression of the IVC and aorta. There's not enough blood flow to the placenta to justify causing hemorrhagic shock in addition to this cardiac arrest. Now, once you do this, you gotta commit to it. If you're gonna do this as a team, this has to be done under 1 minute. So it has to be done fast. So it shouldn't be, kind of cutting down. I'm not really sure. This has to be rapid. And I'll show you a video on how to do it. But this is something that you might want to practice in simulation, so you have it down to less than 1 minute. Now, the recommendations are 4 minutes, but there's plenty of case reports of people going on 15 minutes, 20 minutes. So I can't tell you whether or not it's ethical or not to do it after that. But the longer you're out, the higher incidence of not only maternal neurologic deficits, but also fetal neurologic deficits as well. And the important thing, and this is dangerous, but as someone's doing the incision, as someone's doing the perimortem C-section, it's ideal that you have CPR continuing while this is happening. So as you can imagine, someone's bouncing around on the bed, cutting is going to be very dangerous, so be careful. So the recommendations, we already touched on this, less than 20 weeks, there's no indication to do a perimortem C-section. 20 to 23 weeks, you're doing it primarily for maternal survival. And then greater than 24 weeks for fetal viability, it's maternal resuscitation and potentially fetal resuscitation. Now there's all sorts of kits and fancy things that you can use. Honestly, all you need is a pair of scissors and a scalpel. And this video is a simulation lab, in a simulation lab by Jason Wagner, and I'll walk you through it. So essentially, you're going to make a cut from the xiphoid all the way down to the pubic symphysis. People advise that you put in a Foley catheter, if you can remember, to decompress the bladder so there's not a bladder injury. Once you make that cut down to the perineum, you're going to use scissors to cut down all the way down the rectus. And then you're going to expose the uterus. You're ideally going to use a scalpel at the top of the uterus, and then you're going to use the scissors, being very careful not to cut the baby underneath, cut all the way down, deliver the baby, and most importantly, deliver the placenta, so that the blood flow stops and the uterus starts contracting. What do you do if you get return spontaneous circulation? Well, even without return spontaneous circulation, it's probably wise to do suturing of that uterus and the layers. So what I do is I call in surgery, I call in OB, I want OB to take care of the baby, I want surgery to take care of this, so I can get back to CPR. If you don't have those services available to you, then you're going to take O-silk and you're just going to make big running stitches. This is not cosmetic right now. You just want tamponade bleeding. So big stitches, even staples if you have it, all the way through. Just get things closed and get back to resuscitation. If you get return spontaneous circulation, you want to cool the mother. Targeted temperature management, just as we do. And then, like I said, I load the boat. I have somebody who I'm going to start cutting. I call people down before the incision is made so that they're on board and they can help to outsource some of these tasks. So let me bring it home. Again, the most important systems that you have to pay attention to when you first meet this critically ill patient or potentially critically ill patient in the ED is perfusion and diffusion. Be aware that the cardiac output changes that happen during pregnancy, it's a slippery slope for them and they can decompensate very fast. And the same thing is true of the respiratory system. Don't forget TOLT. Tilt them on their side, give them lots of oxygen, get lines above the diaphragm, know when they're due, and call labor and delivery early. Know how to do a perimortem C-section. Be ready. Do simulation in your hospital and know how to do it in under a minute so that you're safe, your staff is safe, but you can do it effectively once you commit to it. As always, I hope these are tips that you take to your next shift. If you have any questions at all or just want to interact, you can do it right here or you can email me. I'm always happy to hear from you folks. Thank you so much. Have a great day.